Good morning. This is Dr. McDaniel. I'm a board-certified obstetrician gynecologist in New York City, and I'm bringing to you all things health-related for women. Thank you for joining me at the corner today. I'm obviously not at the office. I am at the horse farm. Yes, sitting inside the car because it's actually a little chilly, and today's Saturday. So if you happen to watch the previous presentation, then you're aware that we moved from our office, that location specifically on 35th and 5th in Midtown Manhattan. We moved from there after 17 years straight in the exact same location, and we clocked 17 years in that location and 21 years altogether for my private practice. And I was just around the corner on 35th, on 7th, between 34th and 35th. Then we moved around the corner to 35th and 7th. So altogether in that 35th corner area, Midtown, we were there for 21 years as Midtown Gynecology PC. So we moved down 7th Avenue down to Chelsea. So we're now 26th and 7th Avenue. And I've been an associate clinical professor for NYU since 1997. I did my residency at NYU Bellevue. So I've been a clinical associate professor with NYU since I finished residency in 97, but I've been working for myself. So I joined faculty practice with NYU. So I just relieved about 80% of the stress and responsibilities that I've been carrying for 21 years. I just lifted that off my shoulders, and I'm with the faculty group practice in Chelsea. So it's been really nice to just kind of dump all of the extra stuff that I've been responsible for all these years, to dump all of that in the lap of NYU and to just deal with the patients. So we've been at Chelsea. I keep saying we because it's myself, and of the 3 medical assistants I had hired, who've been working with me for the last 3 years, 2 of them I was able to get them on board at Chelsea also, and it looks like the 3rd one, I'm getting her on board at Chelsea also. So our whole crew, our whole team has moved over down to Chelsea. So it's 26th and 7th if you're in Midtown Manhattan, New York area, or if you're a patient who comes to the office and you didn't get or I guess you did not open or notice the 1 snail mail and the 2 email blasts that we sent out that we're moving, then this is your notice that we're no longer at our usual location. We moved down to Chelsea, but it's only a couple blocks. I just come out of Penn Station, I walk down the street. Instead of taking a left to go to 35th, I take a right and go down 26th. So it's very easy. So that's the big intro. And as the title indicates, today I'll be speaking about the dreaded yeast infection. So most people are aware, but not everyone, that vaginal yeast infections, or what a lot of people call vaginal thrush, is predominantly due to Candida albicans. It's predominantly due to one species of fungus called Candida albicans. Most people are not aware that all of the treatments we have for vaginal yeast thrush are what we call, the treatments are a class called azoles. So when you take the over-the-counter treatment for yeast, which is the miconazole, all of the monostats and the vagisols, vagistat, all of those over-the-counter treatments are clotrimazole, just thought of another one. All of those are in the exact same class of treatment, which is called an azole. The over-the-counter non-prescriptions are azoles, but also the prescription diflucan or fluconazole, it's an azole also. And the vaginal prescription turconazole, as you guessed, you can hear it, it's an azole. So they're all the same class of treatment. So we really only have one treatment for vaginal thrush or vaginal candidiasis, also known as AKA yeast infections. So the catch is, what has been slowly but surely developing over the last 12 years or so has been azole resistance. So the diflucans and the monostats, they treat vaginal yeast infections. Traditionally, about 97% of yeast infections will be treated with either the over-the-counter clotrimazole, miconazole, vagistat, monostat. All of those will be treated exactly the same, because 97% of yeast infections are due to Candida albicans. However, historically, approximately 3% of yeast infections are not due to Candida albicans. There is a different class, or different actually species of yeast called Candida torrelepsis, Candida parapsilosis, Candida glabrata, Candida tropicalis. Those are the 4 additional kind of secondary yeast infections that can occur. So we call them azole resistant. And years ago, according to the research, about 3% of vaginal thrush yeast infections were due to these resistant types of yeast, and the only treatment we could give them would be the prescription vaginal azole called turconazole. The majority of them would respond to turconazole. A very small percentage of those non-albicans yeast would not respond to turconazole. Well, that was a problem, because then we'd started to see that a small percentage of women just were persistently struck with yeast infections, and then we'd really have to roll back the hands of time and try non-prescription mechanisms. So of course, vaginal boric acid, vaginal coconut oil, vaginal tea tree in a carrier, and even coming in for vaginal washes. So we call it vaginal irrigation. And those work a small percentage of the time, but not as easily as just taking a pill by mouth or a vaginal insert. Now, what has been slowly but surely happening is that 3% azole resistant category has been slowly but surely increasing. So now it's no longer just 3% of the time you'll find someone whose yeast infections or vaginal thrush is not responding to the diflucan or monostats. It's closer to 12 to 15%, which is a huge resistant category. And obviously, as I shouldn't say obviously, but most people are aware that when you have a bacterial infection, if you keep partially treating with a specific antibiotic, you're going to develop a resistance to it, because the bacteria divide, they multiply, you get new generations of the bacteria. They keep seeing that antibiotic, and you don't give it enough antibiotic to completely annihilate it. They morph, they develop resistances to defend themselves. It's the old Darwinian survival of the fittest, or they're saying it's not really survival of the fittest, it's survival of the most ability to change, to adapt to change, survival of the most adaptable to change. So we don't traditionally see resistances in fungi, but this is a fairly new phenomenon. We're seeing a fungus that is developing resistances. So now, instead of 3% resistant rate, because you're getting new generations that are basically being born with that capability, we're starting to see 12 and now even 15% in certain populations that are resistant to the azoles, including a small but growing percentage that are resistant to the turconazole, the vaginal prescription azole. That's pretty much our only prescription option for azole resistant or non-Candida albicans yeast infections. So there's a new medication that's been developed to address the non-Candida albicans resistant yeast, vaginal yeast, candidiasis, and thrush, and that's called Brexafemme. So I'm going to leave you on a cliffhanger there, and I'm going to come back on the next presentation and discuss how Brexafemme is going to help these non-azole yeast entities. Thank you for joining me at the corner today. This is Dr. McDaniel. Have a great rest of your day.